yes, PNH Support is charity. It was set up 10 years ago this year. And our mantra is that no PNH patient is alone. All are represented and enabled to live their life to their full potential with PNH. And we cover 3 different areas: support, education, and advocacy. So we do this in our own time. This is completely volunteer run. And we have things like these webinars, peer-to-peer support, personalized advice and signposting. We also focus a lot on the advocacy policy, working with the NHS and NICE on appraisals for new drugs. So that's something that we're now coming to fruition with, and that we've got these drugs on the market and they're available to a wider network of patients. And also we keep an eye on the trials that are coming in, educating patients about them, research, patient rights, and making sure that the PNH patients have a voice is just really important to us. So, where am I? Let me see if I can use the slide here. Just a couple of little things that I thought I would advertise to you before we start with going deep into tablets is that we have this free support. We are a partnership with some other charities, and we've been able to arrange some emotional well-being support. You might be aware of some of the webinars that they already do, and there is one-to-one support available. So if you follow these links, you can find out about the people that run that, and also self-refer if you feel that that's something that you would benefit from. And we also have Robert, who helps us with our benefits advice and support. So if that's something that you're thinking about doing, he is able to discuss your case with you and advise and give you a different perspective and hopefully help you there. As I said, we are 10 years old this year, and there will be an anniversary event and a selection of other events running throughout the year. I'm not going to list them because I'm honest, I don't know all of them. So have a look on the website. There's lots going on, and also it's mentioned in our Instagram page as well. So Maria, I can see a couple of messages on the chat, but I can't seem to open them. Are they relevant to this, or are they things just for later?
No, I've just put the links in for the emotional support and the benefits advice at the moment, and just asking people to keep their questions to the end.
Right then. Oh, and then also, just as we're finishing up with general housekeeping, the Super Rare campaign is running now and through March, and this is where we can raise some money and have some events, help the charity, and help people come together. So again, there's events all over the country. Have a look on the websites, have a look on Instagram. This is a yearly campaign, and hopefully there's something that takes your interest and you can meet up with some other patients. So over to tablets and how you take them, what's going on, what might be going on in your head whilst you're thinking about this. So I tried to put myself in the position of where I was when this was a possibility for me as well. And it might be that you have lived with PNH for years and you've only really known 1 or 2 treatments. So you're curious. Maybe you're new to PNH, you've never really been that ill, and there's a hell of a lot of information floating around and you don't quite know what to make of it. And suddenly there's more medication available and you're supposed to make a decision. Maybe you're a family member or a carer and you just want to be able to support your loved ones the best you can by learning about this and finding out. And then, as you'll see later, and as she's on the screens, we've got Louise with us, who's one of the medical teams. And it's great to have them here because you guys can see them, particularly when, you know, if you're up in Leeds or and you live down in Wales, you don't get to see the teams quite so much, but also so they can see on our facial expressions what's important to us, what we're thinking, but not necessarily saying. So I think this is a case of like, we can all be curious together. So a little bit about me. I was diagnosed in 2017 some seismic shifts, a lot of information. I think I started treatment within 4 days of officially being diagnosed, and it was like, okay, turn up to the hospital. This is what we think you've got. Crack on. Here's the treatment timeline. Have an IV every 2 weeks. Maybe that will work. Maybe we'll change it. We don't know. We'll just have to see. Let's get started. And I was like, um, but then very quickly, 2018 came along, and that was my new normal, both having a son and also having a son and managing IVs at home when you can't bend your elbow and you're getting cold and all that kind of stuff. So that was really intense. And for me, I ended up having IVs every 10 days, which is an intense little cycle. So it wasn't working the best way that I wanted, and I kept asking and asking about different trials, what was going on. I basically was just chewing off the ear of my consultants as to not being happy with what the drugs should be doing and what I felt they were doing. And, you know, my bloods were fine. They were showing that things were okay, but I definitely didn't feel okay enough. So that was why I kept chewing the ears off. And in 2020, I was put through the system to see if I could join a trial for a tablet, which I did. And part of that, I had IVs and tablets. Part of it, I transitioned off IVs. And that trial ran for 4 years. I've since been part of the appraisal process for PNH support's responses to the NICE appraisals to see whether or not these drugs should come to market. And I've been a patient expert on this. Maria and I have worked on the organization's data that we have about this. I'm sure you've seen our emails and filled out the feedback forms about whether or not you've been on a trial and what questions specifically NICE want to hear about from patients when they're considering new medications. And that takes us to the present day, which is that it's a whole new world out there. It's not a case that a long time ago, if you were given a diagnosis, you were just given blood transfusions and expected to kind of limp your way through life. Now there's a selection of medications. It's very much a case where patients can have a two-way conversation with their clinical team to see what's going on and what suits you best. And, you know, there's a lot of blue sky out there. And I think that's something that we should be really excited about. So going back to specifically to tablets, there's a lot of questions in there. Is this going to be the best thing for you? Is it just new and shiny and actually you're quite happy with what you've got going on? Are you really excited about the fact that you might not ever have to have a cannulation ever again or have needles in your home? Or actually, are you also a bit sad about that? Maybe you like having your home care nurse come regularly and have the social interaction with that. Or maybe just being that person who's got to take tablets every day at the same time is a lot of responsibility. And are you questioning, can you stay on track with this? How are you going to do this? Is this that you're swapping out an IV pack for a cabinet full of tablets, and that scares you a bit? So there's a lot of questions and a lot of what ifs, you know, what if you forget to take it? What if you take too much? Do you need emergency doses? Can you take them away with you on holiday? Or is it a case that you think you're going to go and talk to your doctor, they're going to give you some pills, and then they're just going to leave you alone and you don't have anyone to talk to about it? Because all of these are very open concerns. And I felt that when I had my IV, that was a big part of my identity and my diary. And the home care nurse, who was a wonderful person, and I really look forward to seeing her, she was very much a stable part of our family, really. And you know, she could make her own cup of tea in the house, you know, she was very familiar to us. And if that goes, how do you see yourself? And where, you know, this is quite a big crutch, and having a bottle of tablets there's a lot of social interaction that's just lacking from that bottle of tablets. And so how do you feel about that? I think it's important to actually consider it and go, am I okay with that? Is that something I'm willing to take on? Because taking the tablets and going away on holiday is so much more important to me, or, not scheduling my work so that I have IVs at home, but actually I can go into the office when I choose. There's all a balance, really, isn't it? It's all about choosing what you want to work through so that you get the better quality of life for you. And so I want you to think about that, and also consider that you're not alone in this. There's been several different types of trials. So there's, lots of different people who are members of this group who have been on different trials to me, but still taken tablets and had that experience. And just know that you're not the first person who's ever going to make this choice, and you're not the last person who's going to make this choice. So, think hard on it. I would recommend that you just make a list of all the questions that pop into your head and think about all the really silly questions. I'm a firm believer that there are no silly questions. The person that asks the silliest question in the room is asking the most important question, because it's what everyone else was thinking. So, yeah, I mean, go and ask the questions to clinicians. If they have the answer and they've been asked it before, they'll tell you their answer. And if they don't know the answer, they'll go find out, and they'll probably be really entertained that you've found a question that they don't know the answer to, and they've got to go and check it out. I'm always somebody who's busy, got a million questions. There's always a list on my phone, and I plan out which questions I want to ask first with my clinicians so that I get the important ones out of the way, and also because I think they're going to lead into further information that might be useful. So there's a lot of thought going on there, and I would say don't rush that. Sleep on it. Our subconscious works in such a wonderful way that when we're asleep, it's processing everything. And that's when, I mean, I don't know about you, but I get in the shower in the morning, and that's when I have my lightning bolt ideas. And that's probably like the most clever my brain is. And that's when I think, right, yes, I thought about it, or this is where I've joined the dots and I know what I've got to do, and I need to go and write that down. So, think things through, talk it through with a confidant, have a conversation where out loud you're saying these questions to yourself and someone else, and see what they say. They probably will have a different perspective that means that they will view what you're saying in a slightly different manner that could be so useful. And then go and sleep on that again. I like sleep. It's a good thing. So make use of it. And I want you all to know that it's okay to choose to try this, the whole new world of new medications. It's also okay to choose not to try all of these things. If you are happy where you are and it services you and you have a good quality of life and you're okay and you like it, that's okay. And also, you could look at this, you could think about it, and it's okay to choose to try all of this later, rather like Apple updates in the news, what was it, like a year ago, where everyone's been told to go and get the new update straight away, and actually that crashed half the world. Maybe we don't need to rush in. Maybe think about this, have a conversation, go away. Maybe in a year, you know your path and you know what you want to do, and that's okay. So all of this may well change the way you think about yourself, your PNH. Do you view yourself as a patient? Do you view yourself as someone who lives well with your PNH? And going back to that mantra that PNH support has, that we want all patients to live well with their PNH, it is about the individual, and it's about whatever living well means to you. So this is an opportunity to, rather like looking at the crutch of having an IV or having a bottle of tablets, is this something where you can go, do you know what? I've thought about it. Actually, I quite like how things are, and I'm confident that I can care for myself. My PNH is not the center of my world. Or maybe you look at that and you go, it is the center of my world, but I'm also happy with that. So I just wanted to flag that this is a really good opportunity to choose how you want to consider yourself in all of this. And one of the things that I actually have to think about every time I go to the hospital is that back at the beginning of my journey, I was sick and I was going to the hospital to get well. And I was looking at all the people there and thinking, wow, so many. Some people have got physical injuries. You never know what's going on for everybody in the different corridors. And I was like, but this is a place of healing. It's not a place that you go to receive bad news and something bad has happened to you. And I had to really try hard to consider that actually I go to the hospital to keep me healthy and to live well. It's not just because I have a disease that I'm here. I'm here because I'm being cared for, and there's a lot of love and support here for everybody. So, do you want to turn this whole story around and say, no, I check in with these people because I am healthy, and because when I see them, I get an update and I know that I'm looking after myself properly. And one of the things about looking after yourself properly and looking after yourself well, particularly when you have a chronic disease, is that we need a bit of help in prioritizing ourselves. You know, we've got this ultra rare orphan disease that is 1 in a million, and that tells us that we're special. So maybe we should remind ourselves that we're special. And so therefore we need to look after ourselves and prioritize ourselves. Is that you need to make sure that you eat on the days when you really don't feel like it, that you make sure you drink more water before blood tests, the day before a blood test, so that you know that you're hydrated and it's going to be easier to find your veins? Is it that when you're really not feeling that fabulous and you want to stay in, actually a little short walk and a bit of fresh air, you know, will fix you, but it's a bit of an effort? Is it something you can manage? And is it something where you've chosen that decision for you primarily? So, like I said, it's a different way of thinking, and it's about a new way of thinking as well. So we're pretty good at all listening to our bodies. I think this group of people, whenever I've chatted to people, they are astounded by the messages that their bodies tell them. So listen to that, you know, trust your subconscious in this. If you have a niggling feeling that something isn't quite right, or that I had something recently where I had inadvertently turned off the alarm for taking my tablets one evening, and I was convinced that I needed to go in the kitchen, and I could not for the life of me work out why. I was like, the dishwasher is on, I've tidied up, it's getting close to bedtime, I've laid out a cup of tea already for the morning. Like, what on earth is this? I do not know why I need to be in the kitchen. And then my husband was just like, did you take your tablets? And I was like, no. And that was it. That was my brain trying to get me into the kitchen to get a glass of water and take my tablets. So, you know, listen to all of this and embrace the new concepts and the thoughts and everything about it, really. Maybe this is going to be great. Maybe this means that you get to travel. Maybe this means you get to just live life a little bit more freely and less diarized. I don't know. It's all up to you. So this is my exciting metaphor. I hope you're listening, Maria. I've been trying to discuss this with Maria and she's not really understood it. And I was thinking I'm going to talk about it anyway and see if you guys get it. So I thought about this one night, had my lightning bolt in the shower, and that was that when your PNH is disorganized, it feels a little bit like a herd of sheep in a field, and it looks like nobody's really paying attention to them, and they're all dotted around everywhere, and it's all a bit crazy. There seems to be no organization or process involved, and they're just there. And they're just there all the time. And maybe a few of them will be over by a wall. Maybe a couple of them will be down having a drink. It's all over the shop. But really, we kind of want to be more like this. We want to be in a sheepdog trials. Okay, so stick with this. We are the shepherd ourselves, and we have multiple tools to help us with this. We still have the sheep, we still have the PNH, and We're now in a set environment where we are, maybe you're good enough that you're on What Man Is Dog, I don't know, but we've got our field and we've got lots of different gates, and the goal is to get the sheep in the pen. So we want to have our PNH and we want to live well with it organized and how we want it to be. So that means we've got all the different tools of our trade to help us. That could be the crook, that could be your voice, it could be a whistle, it could be a sheepdog, it could be the commands for the sheepdog, doesn't matter. But we have our tools, they are the clinicians, the research information, other patients and peer-to-peer support. We've got our past experiences of what's worked for us, what hasn't, what has meant that we've caught a bug and then our PNH has flared up and you've ended up in hospital. That's all something that you've still logged in your body and in your mind, and you know it's there. And so if PNH is sheep, then we want to be that organized shepherd who wins the trials. We want our sheep to go from the starting point all the way around to number 2, 3, 4, 5, through the gates, end up in the pen where we close the gate and it's tidy and we've used our tools to get there. What do you think, Maria? Yeah, I think you're just nodding because you're like, yeah, Alex, whatever. But these are the tools. These are the things that I've asked people about. I've ended up using myself. Some of them work, some of them don't, some of them change them up. But the first one I would say is if you are considering this, then be organized, be hyper organized. You know, I have 2 alarms on my phone, 7:45 in the morning and 7 p.m. in the evening, that tell me to take my tablets. I might take them a little bit early, but the alarm is there and I'm not allowed to turn the alarm off until I've taken the tablets. You might want to use your phone to log your tablets or keep them in a paper diary. I would certainly say have your like big, you might end up having like a big pharmacy type cabinet with lots of tablets, but add in your daily vitamins. People talk sometimes about habit stacking, which is if you need to get a new habit, you attach it to something that you already do with ease during your day. So if you take vitamins every day, you can take your tablets every day, time it so that it all happens at the same time, and then use that recurring alarm so that you know that you've done it. And then set a recurring alarm in your diary or your calendar so that you know when you need to reorder your tablets as well. That can be quite a tricky one because people forget about bank holidays, pharmacies not being open. If you think about Christmas or Easter, you're always told that if you take prescriptions, you should make sure you've got enough to get you through a bank holiday weekend. So the same goes for all of this. And also, like, always have tablets on you. Make sure that you have some that live maybe in your car, maybe in a drawer at work. You can get like little metal tablet carriers that live on key rings, like just on Amazon and stuff. But have one of those and keep it somewhere safe. Keep it in your underwear drawer. I don't know, wherever you want. But make sure that you've always got more than you need somewhere. And think about that when you're also traveling. Think about the bank holidays, but think about if you're traveling and you wanted to stay a little longer or a flight was cancelled, would you have enough of your antihistamines, for instance, to cover you to get home? Well, think about that in the same way with your medication here. If you're traveling, make sure you add in extra doses in case something happens. And then also consider that you might need to order extra so that you've got extra at home. You don't suddenly use them all up and then find you've got none when you get back. And I'm sure a few of you probably already have a letter that you might have for traveling. Certainly if you were using some of the subcut injections, or you've ever had to travel with any other medication, you need a letter. So make sure you get one of those in advance. Basically do it when you don't need to, so that when you do need it, it's there. And I've written here about having a support network, which in that story about not knowing why I needed to be in the kitchen, that was my husband, who has learnt that I will probably snap at him and find it really condescending if he asks me have I taken my tablets, except for the occasions when I haven't taken my tablets. And actually, I do need to be told off in a very condescending manner because it's really, really important. So he also checks that I've packed my tablets if we're going away, and knows full well that I will do it in a quiet place where no one can talk to me so that I get it right. And then it will be right and it'll be calm and everyone can relax. A little bit like passports. You don't want to be grabbing them in a rush. You want to make sure they're packed at a calm point when you know they're in your handbag and you know that they're with their house keys and all the other important things that you need. So, be hyper organized with all of this stuff. And I wrote a list of helpful things that I found worked for me when I was at the beginning of the trial and I was taking tablets. And it started out with when you're swallowing big tablets and vitamin tablets, it could be that you need to drink them with kefir instead of water to help you swallow. And it's gone down, and this list is quite long and arduous, but I will put it in a PDF, and perhaps we can put it on the Facebook page, or we can send it to everybody's here so that it's just something there. Maybe it would be great if other people could share things that they've learned or little hints and tips as well, because I think it's very much a case of like living experience is the best way for other people to learn about this. So I've popped on here as well the medical team. When you have an upcoming appointment, plan what you want to discuss and ask all the questions you can think of. One of the ones I remember asking was that I wanted to know the size of the tablets because I was having a really hard time swallowing. And I think I got the answer back that it was a class 1 size or something, or size 1 or something. It's something completely arbitrary and I had no idea about. And I was like, right, well, I want to see them. And yeah, they look like horse tablets. They were enormous. But if I hadn't have asked that question, I would have gone home with them and then had a bit of a panic about what on earth I was going to have to do. But actually, I asked the question when I was at the hospital. Someone showed them to me, and then someone else was like, take them with kefir, take them with a yogurt drink, or pointed out that if you take them and you start to get better, the problems you're having might go away and it might not bother you. So ask all the stupid questions you can think of, and then probably chuck in a few extras just to ask some more stupid questions. So I hope that this is all useful, and I want you to know that you're not alone in this. I wanted this to be a conversation for patients so that they understood that someone else has done it, and that's great. And you can learn from that to help you off first. And we've got everybody who's on this webinar. We've got we've got that emotional wellbeing support. We've got our clinicians, but we have lots and lots of people around us who love us and want to help us. So let's utilize that the best that we can, So I really hope this is kind of empowering for everyone. And the clinicians, as we know, we've got our Leeds team and we've got our Kings team covering England, Wales and Northern Ireland. And as I mentioned before, we've got Louise with us, who works out of St James's at Leeds. So she will be your nurse for some people and she will be somebody you don't know for others. So Louise, do you want to take over and give us your thoughts?
Yeah, good morning. Thanks, Alex. That was an incredibly eloquent talk, and I really can relate to a lot of that for the conversations that I've had. For those of you that don't know me, I'm Louise Arnold, and I'm a haematology nurse through and through. I currently practice as an advanced clinical practitioner in the St James's service, but I've been there for a little while and do come from a London-based team originally, which all moved to King's. So I have a connection to both teams, but if you're being reviewed in London, I may not have met you before. So I think just to add to what Alex said, it's been a big shift in the world of PNH, as we all know. But if you're new to PNH, then that's kind of a different place again. And I think what you've just explained, Alex, really helps relate to that. We've gone from a scenario where you've had no therapy to choice in therapy in the UK, and we're very privileged in that way, and have a very varied way of looking at how PNH can be managed and supported therapeutically when required. So I think that that's really, really key here. And I think it is a case of working together and very much doing that as one thing. And as Alex says, that people are very loved, and I can't express that more. I had a experience in clinic this week where I was asked about PNH from the beginning of therapy. We talked about how when I was first a staff nurse in haematology, and we were giving patients blood transfusions and blood thinners and things to manage PNH, and there was a very different picture to then the first therapy that was the IV, to now having areas where you can have different approaches to it, including tablets. And I think that is very, very significant in working together, because it is a very individual experience, and there is very individual ways of managing that. And some of that is directed by the clinical picture and symptoms and blood counts and different things, but also there is that element of what works best for an individual. And I've sort of experienced that in both sides, as Alex sort of alluded to, in the sense of how that is right for an individual, and that's very much how we approach it from a clinical point of view as well. And the experience of the clinical trials brings that together, but also it's the real life experience which is the most important part, which I think was what we've just heard from Alex there, and most key in how we do it. I think I'll go back to you, Alex. Do you want me to answer questions from this point of view, because I know the presentation was supposed to be for like 45 minutes, or how would you like to sort of
well, I think I'm very happy to go to questions and see if anyone's got some, since I could not have made a bigger plea for stupid questions. But
I'm just very conscious of not allowing, I want to allow enough time. That's what I mean.
Yeah, sure. I think one of the things that you started with there was that there's a difference between the patients that are new to this and the patients that are experienced, in that they might have an idea of different treatments, but also they have an idea of what it's like when you're in hospital because you've had a PNH flare-up. And if you're transitioning from any medication, you've got to have a period of time where you are learning how your body reacts to that. And if you, for instance, if you just get a cold and it's cold and nothing happens, or if you get a cold and then that's going to start the chain reaction of your PNH. So where this is for tablets, what are the things that people need to look out for? What are the things that are the dangers for, say you took too much or you missed a dose? Like, what's going to happen, and what should you be aware of to help you make the right choice for your treatment?
Yeah, I mean, I think with anyone with a diagnosis of PNH that indicates that therapy is the right way forward, there is that understanding that obviously the drug is managing PNH rather than taking it away. So we know that underlying there is a level of PNH activity that's possible if there is a challenge to that management. And I think whether that is with an IV, a subcutaneous treatment, or an oral tablet, it's responding to how that impact is if there is a challenge, such as an infection or a virus. And I think that comes in different states, because if you've lived through PNH type symptoms and had hospital admissions with an infection and needed blood transfusions, or a visit to the day and blood transfusions, that can be quite prominent. But if if it's new to you, or you've been very well for a long time, and this is, someone mentioned this to me this week, they'd been so well on therapy without any concerns for a long time, and then did get an infection and had kind of forgotten about the fact that the PNH symptoms could come back a little bit. So I think the key thing in that situation is if you're having the tablet type treatment, then if there is any evidence of symptoms of PNH, and the same with any other treatment, is to contact your healthcare team. So either the Leeds or King's team And obviously the liaison with the local team is just as important as well, and that can be managed as a multidisciplinary approach with all of us involved, to get the right support. But from the point of view of tablet taking, obviously if there is a missed dose, we advise to take it straight away and contact the team. I think that's the best way. If there are any evidence of symptoms, there's management of those symptoms, which may be adding in a dose of an IV if it's acute to get it into the system sooner. But that would be very much on an individual basis from that point of view.
So just sort of like looking after yourself in the same way, doing everything that you would normally do.
Yeah. And I think, sometimes you see a really good response to a therapy where the hemoglobin is maybe better on one treatment to another treatment, depending on the individual case. It's different for different people. And, if someone is unwell, it may be that their hemoglobin has come up nicely on the therapy they're on at that, and that there is a drop in the hemoglobin. So it's managing things like that, whether there's a need for a transfusion, but also whether there is a need to address the reason for it, which is the infection or the challenge to the system. And that's, to me, and I've never changed in the 20 plus years I've been around people that have a diagnosis of PNH. Is communication is key. I also love questions that challenge me, but I like the silly questions the most, because that means someone's really thinking about it and they're confident enough to ask those questions. And I think there is never such a thing as something that's silly. It's just asking those right questions, isn't it, that satisfy your confident in what you're doing and how it is for you. And but yeah, I definitely like it when someone asks a question that you don't know the answer to as well, because it does bring people together and talk about it. And as a multidisciplinary team between the whole National Service, we do discuss things a lot and talk about it and share that information, and that is vital in an area that is a rare disease.
Yeah, totally. Totally. I love that idea.
And as an international community as well, we very much do that. So, it is key to that management in something where you have less people. So you want to share that knowledge and information. And we've been talking to people in Africa this week and different places, and it's just getting all that shared collective understanding, across every corner that's possible to make that understanding better.
Alex, there's a question in the chat. Should I read that out? So, what makes a patient clinically eligible for this medication? Louise, are you able to give us some?
Do you mean there is 2 different oral tablets that have just come onto the market and been approved now for use in England at least. And for iptacopan, which is I presume what we're talking about mainly, is eligible for everybody in the UK now, frontline as well. So the eligibility is if there is hemolytic PNH. There only one caveat: if someone has had a thrombotic episode before and doesn't have hemolysis at the time, there is a bit more discussion around that, but it is eligible frontline for upfront. So for anybody to have it, or they can switch from another medication to it. There may be a little bit of management around that, but it is a possibility. However, I think, as Alex alluded to, it is something that needs to be discussed and thought about. Treatment is not something that we change straight away without consideration, but patient preference and choice can be part of that consideration as well. So it's just looking at the picture and making sure it's the right thing for that individual.
Thanks, Louise. There's another question in the chat. Shall I carry on reading that out? Is that okay? Are you happy with that?
That's not coming up for me, so yeah, that'd be
So next question is it the same time that you take the tablet daily, exactly the same time, or is there flexibility within sort of an hour perhaps around that time?
Yeah, I would always advocate for the time frame to be tight as much as possible, and if you can take it at the same times every day, that's the ideal. Obviously there is a little bit of flex in that, and an hour or so either side, it would probably be okay, but I would advocate that getting it as much near as the same times and the equally spaced during the day. So it's sort of 12 hours apart if is preferable, but obviously there's got to be a little bit of flex there. And I think even if I say what I do, if I was taking it myself, I would be like Alex, sometimes you need a reminder from somebody else in the house, or different things, you do need to accept that there may be a bit of a delay or take it a bit early some days, but as much as possible, I would keep it regular. Yeah.
I think as well, I'd add to that, like, make it easy for yourself. That, you know, make it as easy as possible, so that if you take something, if you, like I said, with vitamins, if you're going to take them at breakfast time, then work out the equal time that's the opposite and take your evening doses then, rather than sort of being unsure or thinking like, oh, I might be going out that evening, I'll take them later. Don't do that. Just make sure you take them when you need to and make it as easy as possible. So have them in a little travel tube that's on your key ring, or have a packet in your bag all the time. I mean, if I think about the amount of times that I've been out with friends and someone's just popped a paracetamol because they've got a bit of a headache, no one makes a big deal about this stuff. So just make it as simple and easy as possible, so it becomes part of your life and your habits without you even noticing.
Yeah, and no, 100% agree, and that has been one of the things we've discussed a lot. And I was like, well, there is a lot of conditions where we take a lot of tablets, but also where we've had people taking intravenous and subcutaneous treatments to manage PNH. There's also the recommendation of the prophylaxis for the meningococcal risk. So a lot of people are already on penicillin or such twice a day anyway. So it's kind of building that into the same pattern. I think it's just that it's very evident there's a lot of anxiety around how we manage this, in the sense of we don't want to miss it, but obviously it's also taking that fear out of that and just being able to manage that, and that we can just continue with it as something that, like you say, is as normal as taking a pain relief.
Yeah. So just moving on from the penicillin you mentioned, Louise, there is a question in the chat about danicopan and taking it with penicillin at I think it means at the same time, but we can clarify that in a sec if that's not what's meant. So can you take danicopan and penicillin together? So it might be useful if you could give a brief explanation about the difference between danicopan and iptacopan, just in terms of how one is a monotherapy and one is not, if that's okay.
Yeah, I am going to have to just take 5 seconds though. Unfortunately, my computer has just decided it's going to turn off, so I'm literally going to go and grab my cable. So can I answer that in 2 seconds? It's just down.
No problem. While Louise is doing that, maybe Alex can answer any other sort of questions from people here that don't require a sort of a medical opinion. I know there's a question in the chat about the difference between the two different tablets, but we'll leave that until Louise comes back. But if there's any other questions that anyone has, that Alex might be able to answer for you from her experience of taking different kinds of tablets over time, that would be good.
Or if there's any questions about like travel or you know, being away from home with tablets maybe, or something like that. One thing that I didn't get around to doing, but I was thinking about adding into here, was that where we were talking about being organized with your pills, and having like a little pharmacy cabinet type style. You know, when you have a box of tablets, if you're on you know, an antibiotic set for a couple of weeks, not for a long time, you might get multiple boxes that all say 1 of 3, 2 of 3, 3 of 3. And what I would suggest to people is that you don't just chuck all your tablets in a cupboard. Like, organize them and stack them so that you have box 1 of 3 at the top, then 2 of 3, then 3 of 3, and then have the next stack, and then have the next stack, and be really, really overly ordered with this, because it's just another layer of you knowing that you're in charge of it and being confident with it, so that you can see your stocks declining, and you know that you've got enough if you want to go away from home. You know that you've got enough if there's a bank holiday coming up, or you look at it, you open the cupboard one day and you're like, oh, that's weird, there's only half a box left, and you know for a fact that you need to go and order some more. And I think when Louise comes back, we might ask about the home care arrangements, because I think that's something that's been set up very recently, and it would be nice to know what the process is for you guys so that you can also consider that. I hope that's helpful.
So there are some questions in the chat. Thanks, everyone. I think a lot of them relate to things that Louise will be able to answer. So there's something about ordering the tablets. Louise does need to clarify that there are 2 different PNH tablet treatments at the moment. One is taken on its own, which is called iptacopan, and the other one is taken alongside an infusion called danicopan. So we'll get her to clarify the answer to your questions when she's back. But if there are anything, is there anything else people would like to add? It looks like she's almost ready.
One thing I would quickly add as well is that I hope I didn't scare anyone with my story about swallowing horse tablets, because that's not what it is. And also, the trial that I was on was not for iptacopan or danicopan, and the tablets changed several times whilst I was on my trial, from quite big ones to smaller ones, but lots of them. So, you know, what we're discussing and things might sound a little daunting, but I think it's all manageable, and none of the tablets that I've seen recently have been larger than a normal capsule. So I hope that aligns some concerns as well.
Sorry about that.
Okay. No problem.
Sorry.
Do you want me to?
I moved rooms earlier because of my dog, and then I hadn't taken my cable, so the net had been moved. So apologies.
Would it be helpful for me to just read out the questions that we think would be great if you could answer for us?
Yeah, I'll do my best.
No problem. So with the first one, I guess, would it be okay if you just gave a brief explanation about the difference between iptacopan and danicopan?
Yeah, so iptacopan is a single agent drug that's taken twice a day, and that is a treatment to just manage PNH from any angle. It has been licensed, as I say, in all areas of PNH, and only has the caveat of starting it in someone that's had a thrombotic episode and doesn't have any hemolysis at the time, so there may be a bit of precaution around management there. So if someone is on a treatment at the moment, it is possible to switch to that with discussion with the clinical team around the best idea from that. And like I say, that is something that can be patient driven. But also, you know, we're very mindful of not just switching treatments without a thought process around that. And then danicopan is a oral medication that has been developed to add on to a C5 inhibitor, such as ravulizumab or eculizumab or crovelimab or the biosimilars, and that is where someone has some extravascular concerns. So there is still a bit of what we call breakthrough. So there is a few bits of symptoms, whether that's on blood counts or whether with physical symptoms that people are experiencing. And it may just help manage and boost how somebody is feeling. And that's taken 3 times a day. And maybe in someone that isn't keen to just be on an oral medication alone, or whether it's not appropriate from the point of view of various clinical reasons. So it's sort of getting that right for the individual, as I say. So it's also just managing those that have had concerns such as thrombosis in the past as well, maybe a better way of doing it.
Thanks, Louise. Do you take penicillin with danicopan and iptacopan while we're there?
Yes, because the penicillin would be for anything where there is risk of meningococcal infection. So where you're blocking complement. So if we go back to complement in the sense of it being a set of events that occur within us all the time when something comes into the system, such as an infection, the end part of complement deals with meningococcal infections. So when we give treatment for PNH, we're sort of stopping that end part of complement, so stopping those dominoes falling over. So that last part of our immune system is stopped, and that stops your symptoms of PNH, but also can put you at slight increased risk of meningococcal type infections. So we give the penicillin or various other antibiotics if you're allergic to try and prevent that risk of meningococcal infection. So we would still continue that with any of those medications, is the short answer.
Thank you very much.
Can I jump in there as well and just say that if you want to remind yourself about meningitis and the meningococcal processes, or you aren't sure about that and haven't really discussed it, we have a previous webinar. Is it on our website, Maria? But we have a previous webinar that Louise did with another one of our members, who kindly spoke and did a video about what happens because she has survived it. So I would really recommend that people go and look at that, because the meningitis risk is quite eye-opening and quite large, and it's good to remind ourselves every so often.
Yeah, and that's why, you know, to cover that completely is why. Oh,
you've frozen, Louise.
I think something must have come up. She gave a bit of a surprised noise. Perhaps her computer's restarting or something. So just looking at the other questions we've got, Alex, do you know anything about tablet stock and how many you get at once? Because there's a question about they only last 2.5 months at the moment, and that might not be long enough. Do you know anything about the about that before Louise gets back?
When I've received, I'm now on IPTA, and when I've received that, I've had 3 months supply, and I ordered it so that I would have an overlap, so that I always have 1 month remaining when I get contacted by the home care team, so that I never need to really stress about it. So I think it comes in 3 months. What's that? 12-week, I think. But again, that might be different for different people, or it might be different according to if you're at different parts of the country. I don't know is the simple answer, but maybe
I can help, Alex. Yeah, sorry, I'm so sorry. IT is not my friend today. I do apologize. I'm a bit embarrassed now.
I think you have the perfect excuse to go and sit in a dark room later and just be like, no, can't be near anything electrical.
I don't know what's going on. I do apologize. Were you talking about supply of medication?
Someone was asking it specifically about how much you get when it's supplied, but if you also elaborate
home
around
care as well, yeah,
the home care process, right?
Yeah, so if someone is agreed that someone's going to go ahead and they've consented and everything to go on to an oral medication such as the iptacopan or the danicopan, we would by choice start somebody in hospital on the medication, no different to an IV or subcutaneous. We would still like to do the first dose within the hospital environment. For those of you that are at Leeds, sometimes we can do that at the outreach clinic, ideally with somebody from the service, but alternatively it can be done locally, but it's not our preferred way. So from a practical point of view, home care are involved, so home care will be delivered. We're using the same home care companies as we do for IVs and things, so it's like Healthcare at Home or CNCS, HealthNet, and it's no differences from anyone that we already know, but obviously the interaction is slightly different. So the deliveries initially will be after that first dose in hospital. It would be a 28-day cycle, so we would give everybody a month's worth, and then from our point of view, we sort of ring the day after somebody's had the first dose to see how they are, and then we would do a nurse follow-up in like 2 weeks. And if everything's okay and happy to go ahead, they would then do a 3 months delivery, and that would be via the home care company. So the delivery would be to your home via a company, the same as you already know. For danicopan, it's slightly different in the sense of we've tried to get it to be delivered around the same time as the therapy, such as the IV, but obviously that's logistically proving a slight challenge at the moment, but I'm still on a mission to see if we can make that marry up. But we would initially do like a 28-day the same, just so you've got that period of time just to have that review and see. So hope that makes sense, in the sense of it, in the long term it would be a 3-month delivery to home.
And Louise, who orders that, the clinic or the patient?
The clinic. So it's based by the prescription in the same way we generate the IV infusion. So when we monitor everybody's prescriptions, we have a whole network of how we look at it, and we do that from the nursing perspective in Leeds. So we will trigger when somebody needs it sort of 6 weeks before. So then one of the prescribers would prescribe it, and then it goes through pharmacy for the checks, then it's sent to home care for delivery, if that So it's a bit of a process, but it's done in the background. Obviously, patients are, we wouldn't want to leave that responsibility, but obviously very welcome to be involved, and if there is any questions around that, and deliveries. Obviously it's new to us as well.
Great, thanks so much. There's a couple more questions in the chat, and I might then turn the recording off so that anybody who wants to actually verbally ask their question to you or clarify something that they've already tried to ask in the chat can do so without being recorded.
Sure.
So there's a question about taking a tablet on an empty stomach, and whether if someone had forgotten to eat, then had something to eat without thinking about it within an hour of taking the tablets, is this problem?
It shouldn't be. No. You've got to carry on, with life as well, and sometimes it's just, it would be fine, I'm sure. Yeah, just go ahead.
And just coming back to the danicopan and penicillin question, I think the question meant, can you actually take them at the same time, sort of one after the other? Is that problematic in terms of timing of when you actually swallow them? I think that's what it means. But if that's not right, I can turn the recording off in a sec and we can get clarification.
From my knowledge, I don't think that's a problem, but that is, like Alex alluded to before, is asking questions that we don't know. I don't remember that being an issue at all, but I will clarify that and come back to you, so you can have that information on the website. But I personally wouldn't have considered any concern from that, no.
Thanks, Louise.